I want to begin today by acknowledging something that I think most people watching this have probably felt at some point. You've been doing what you were told. You've been taking your medications faithfully. Every morning, maybe every evening too, you line up those pill bottles and you take what's been prescribed. And you do this because you believe reasonably that this is what responsible people do. This is how you take care of yourself. This is how you stay healthy. And in many cases, that's true. Medications save lives. I've seen it happen countless times in my career. But here's what I've also seen, more often than I wish I had. Patients in their 70s and 80s who are taking 5, 6, sometimes 10 or more medications, and they're slowly getting worse. Not dramatically worse, not in ways that set off alarms, just gradually declining. They're more tired than they should be. They're a little unsteady on their feet. Their memory isn't quite what it was. Their digestion is off. They don't sleep well. They feel foggy or weak or just not like themselves. And when they mention this to their doctors, what do they hear? Well, that's just part of getting older. Maybe. But in my experience, a lot of the time, it's not aging at all. It's the medications. This is something that doesn't get discussed nearly enough. The hidden cost of long-term medications after 70. Not the obvious side effects, the ones listed on the package insert, but the subtle, cumulative burden that builds up over years when you're taking multiple drugs that were never really tested in people your age. That's what I want to talk about today. Let me start by explaining something fundamental about how the body handles medications, because this is really the heart of the issue. When you take a pill, your body has to process it. The drug gets absorbed through your digestive system. It enters your bloodstream. It circulates through your body. It does whatever it's supposed to do. And then eventually it has to be cleared out, usually by your liver and your kidneys. This whole process is called pharmacokinetics, if you want the technical term. And here's what happens to pharmacokinetics as you age. Everything slows down. Your liver, which metabolizes most medications, becomes less efficient. The enzymes that break down drugs don't work as quickly. The blood flow to your liver decreases. A medication that a 50-year-old might clear from their system in 6 hours might take twice as long in a 75-year-old. Your kidneys, which filter drugs out of your blood and excrete them in urine, also decline. Even in healthy older adults, kidney function drops significantly with age. By the time you're in your 70s, your kidneys might be working at 60 or 70% of what they did when you were young, sometimes less. What does this mean practically? It means that the same dose of medication produces higher blood levels in an older person than in a younger one. It lingers longer. It accumulates. A dose that was perfectly safe when it was prescribed to you at 55 might be too high when you're 75, even if nothing has changed about the prescription itself. And here's what often happens. Nobody adjusts the dose. You just keep taking what you've always taken. Now, let me complicate this picture further, because it gets worse when you're taking multiple medications. The average American over 65 takes about 5 prescription medications. Many take more. I have patients who are on 12, 15, even 20 different drugs. Each of these medications has its own effects and its own side effects. But when you combine them, you don't just add the effects together, you multiply the complexity. Drugs interact with each other in ways that are often unpredictable. One medication might slow down the enzyme that processes another medication, causing it to build up to dangerous levels. Another combination might have overlapping side effects that compound each other. A blood pressure medication that makes you slightly dizzy on its own becomes a serious fall risk when combined with a sleep aid that also affects your balance. This is called polypharmacy, the use of multiple medications at the same time, and it's become epidemic in older adults. The research on this is quite clear. The more medications you take, the higher your risk of adverse drug events, falls, hospitalizations, cognitive impairment, even death. And the truly troubling part is that many of these complications don't look like medication problems. They look like aging. They look like new diseases, Patient falls and breaks a hip. Must be age-related frailty. Let's add a bone medication. Patient is confused and forgetful. Must be early dementia. Let's add a cognitive enhancer. Patient can't sleep. Here's a sleep aid. Patient is anxious. Here's something for anxiety. And the medication list grows, and the problems deepen. I've seen this pattern play out hundreds of times. Let me tell you about a patient I'll call Margaret. Margaret was 76 when I first saw her. She'd been referred to me because her family was worried about her memory. She was forgetting appointments, losing track of conversations, occasionally getting confused about what day it was. Her family doctor had suggested it might be early Alzheimer's disease and had recommended a specialist evaluation. When I reviewed Margaret's chart, here's what I found. She was taking 11 medications, a statin for cholesterol, a beta blocker, and an ACE inhibitor for blood pressure, a proton pump inhibitor for acid reflux, metformin for borderline diabetes, a thyroid medication, aspirin, vitamin D, calcium, a sleep aid that she'd been taking for years, and more recently, a low-dose antidepressant because she'd been feeling down. 11 medications, all prescribed for legitimate reasons, all by competent doctors who were trying to help her. But when I looked at the combination, several things jumped out. The sleep aid she was taking, a benzodiazepine, is known to cause cognitive impairment in older adults. The research on this is very solid. Long-term use of these drugs is associated with confusion, memory problems, increased fall risk, and even increased risk of developing dementia. The proton pump inhibitor, which she'd been taking for years for heartburn, can interfere with vitamin B12 absorption. B12 deficiency causes neurological symptoms, including memory problems. The beta blocker can cause fatigue and depression in some patients, which might explain why she'd been feeling down and why she was then started on an antidepressant. And the blood pressure medications combined were bringing her pressure quite low, which is appropriate in some patients, but in others can cause dizziness, fatigue, and cognitive dulling. I ordered some blood tests and found that her B12 was indeed low. Her blood pressure readings in my office showed significant drops when she stood up, orthostatic hypotension, which explained why she'd been feeling unsteady. Margaret didn't have Alzheimer's disease. Margaret was suffering from the accumulated burden of years of medications that were no longer serving her well. Working carefully with her other doctors, and I want to emphasize, this needs to be done carefully, not abruptly, we gradually reduced her medication load. We stopped the sleep aid and helped her develop better sleep habits. We discontinued the proton pump inhibitor and addressed her reflux with dietary changes. We adjusted her blood pressure medications to more appropriate levels for her age. We supplemented her B12. Over 6 months, Margaret's memory improved significantly. Her energy came back. She stopped falling. She didn't need a dementia medication. She needed fewer medications. Now, I want to be very clear about something. I am not saying medications are bad. I am not saying you should stop taking your prescriptions. Please don't misunderstand me. What I am saying is that the balance of benefits and risks changes as you age. A medication that was clearly appropriate when you were 55 may no longer make sense when you're 75. And very few patients, and honestly, very few doctors, take the time to reassess that balance. The system isn't set up for reassessment. It's set up for continuation. Once a medication is on your list, it tends to stay there. Inertia takes over. The busy primary care doctor, who has 15 minutes for your appointment and 20 other concerns to address, doesn't have time to carefully evaluate whether each of your medications is still appropriate. And there's another factor at play: fear. Doctors are often afraid to stop medications because we worry about what might happen. What if we stop the statin and you have a heart attack? What if we reduce the blood pressure medication and you have a stroke? These are legitimate concerns. But what we often don't weigh adequately is the other side. What is happening to you right now because of these medications? What is the ongoing cost of continuing them? Let me walk through some of the medication classes I see causing the most problems in older adults. Blood pressure medications are probably the most common. And please understand, I am not against treating high blood pressure. Uncontrolled hypertension is dangerous. It causes strokes, heart attacks, kidney failure. Treatment is important, but here's what often happens. A patient is started on blood pressure medication in their 50s or 60s, when their pressure was genuinely high. Over the years, additional medications are added because the pressure isn't quite at target. By the time they're in their 70s, they might be on 3 or 4 blood pressure drugs, and nobody notices that the blood pressure goals that were appropriate at 55 may be too aggressive at 75. The research on this has actually evolved quite a bit. We used to think lower was always better. Now we understand that in older adults, pushing blood pressure too low can be harmful. It increases the risk of falls. It can impair cognitive function. It can damage kidneys that are already stressed. I see patients all the time whose blood pressure is being pushed down to levels that would be fine for a 50-year-old but are too low for them. They're dizzy. They're fatigued. They're falling. And nobody has connected it to the blood pressure medication because on paper, their pressure looks controlled. Sometimes the most helpful thing I can do is reduce their blood pressure medication, let the numbers come up a little, and watch them feel dramatically better. Statin medications for cholesterol are another category worth discussing. Statins have genuine benefits. For people who've had a heart attack or stroke, they reduce the risk of having another one. The evidence for secondary prevention is solid. But for primary prevention, that is, for people who have high cholesterol but haven't had a cardiovascular event, the picture is more complicated, especially as you age. The benefits of statins diminish in older adults. The major studies showing benefit were done primarily in middle-aged populations. When you look at the data for people over 75 or 80 who don't have established heart disease, the benefits become much less clear. At the same time, the risks become more apparent. Statins can cause muscle pain and weakness. This is well documented. What's less appreciated is that this muscle effect can contribute to falls and disability in older adults. They can also affect liver function, and there are ongoing questions about cognitive effects, though the research is mixed. I'm not saying everyone should stop their statin, but I am saying that a 7-8-year-old who was started on a statin at 55 deserves to have someone reassess whether the medication still makes sense for them. The calculation has changed. Proton pump inhibitors, the acid reflux medications like omeprazole, pantoprazole, and their cousins are vastly overused. I say this without hesitation. These were originally approved for short-term use. 8 weeks, maybe 12. For healing stomach ulcers or severe erosive esophagitis. Instead, they've become maintenance medications that people take for years, sometimes decades. They get started for relatively minor heartburn and never stopped. The problem is that long-term use carries real risks. These medications reduce stomach acid, which sounds good if you have reflux, but stomach acid serves important functions. It helps you absorb nutrients, calcium, magnesium, vitamin B12, iron. It helps kill harmful bacteria in your food. Long-term PPI use has been associated with increased fracture risk, probably from calcium malabsorption. It's been linked to kidney problems. It increases the risk of certain infections, including a particularly nasty intestinal infection called C. diff. There are concerns about dementia risk, though the data is still being sorted out. And here's the really frustrating part. When you try to stop a PPI after long-term use, you often get rebound acid production. Your stomach, which has been suppressed for so long, overcompensates. You get worse heartburn than you had before, and so you conclude that you need the medication. But that rebound is temporary. If you can taper slowly and get through it, many people find their reflux is actually manageable without the medication, especially with dietary changes and other strategies. I've helped many patients get off long-term PPIs. It takes time and patience, but it can be done. Sleep medications deserve special attention because they are particularly problematic in older adults. The most common ones prescribed benzodiazepines like lorazepam or temazepam, and the Z drugs like zolpidem all carry significant risks in older people. They increase fall risk substantially. They cause daytime drowsiness and cognitive impairment. They can worsen breathing during sleep, and with benzodiazepines in particular, there's growing evidence linking long-term use to increased dementia risk. These medications also lose effectiveness over time. Your brain adapts to them. You develop tolerance. The same dose that used to put you to sleep no longer works as well, so you need more. Or you need something stronger. And you can't stop because now you have withdrawal insomnia on top of everything else. I understand why people take these medications. Insomnia is miserable. When you haven't slept well in weeks, you're desperate for relief. But sleep medications are not the answer, especially for long-term use. They don't give you quality sleep. They sedate you, which is not the same thing. You might be unconscious for 7 hours, but you're not getting the restorative deep sleep and REM sleep that your brain needs. What works better? Addressing the underlying causes of sleep problems. Sleep hygiene, boring but effective. Cognitive behavioral therapy for insomnia, which is actually more effective than medication in the long run. Managing conditions that disrupt sleep, like pain or sleep apnea. Sometimes, carefully, melatonin or other gentler approaches. Getting off a long-term sleep medication is hard. I won't pretend it isn't, but it can be done, and many of my patients who've done it report that their sleep and their mental clarity actually improved afterward. Let me tell you about another patient. I'll call him Donald. Donald was 73, a retired postal worker. His wife brought him to see me because she was worried about changes in his personality. He'd become more irritable, more anxious. He was having trouble with his memory. He was falling asleep during the day but couldn't sleep at night. Donald had been taking lorazepam, a benzodiazepine, for about 8 years. It had been started when he was going through a stressful period at work, and nobody had ever taken him off it. He was also on a statin, a blood pressure medication, a medication for overactive bladder, and an over-the-counter antihistamine that he took every night for allergies. This combination was devastating. The benzodiazepine was impairing his cognition and disrupting his sleep architecture. The antihistamine, which most people don't realize has significant anticholinergic effects, was adding to the cognitive burden. The bladder medication was also anticholinergic. He was essentially getting a triple dose of drugs that all impair brain function in older adults. No wonder his wife thought something was seriously wrong with him. We worked together over many months to slowly taper the benzodiazepine. We switched his antihistamine to something with fewer central effects. We discontinued the bladder medication and tried behavioral approaches for his urinary symptoms. It took about 8 months. There were some difficult weeks, especially during the benzodiazepine taper. But by the end, Donald was like a different person, more alert, less irritable, sleeping better. His wife said she had her husband back. The medications had been stealing him from her. We got him back. I want to spend a moment on something called the anticholinergic burden, because it's a concept more people should understand. There's a class of effects that many common medications share. They block something called acetylcholine, a neurotransmitter that's important for memory, attention, and many bodily functions. Drugs with anticholinergic effects include many antihistamines, bladder medications, some antidepressants, some medications for nausea, some muscle relaxants, and others. Individually, each might have a modest effect. But when you're taking multiple medications with anticholinergic properties, the effects add up. There's actually a scoring system we use to calculate anticholinergic burden. And we know from research that higher scores are associated with cognitive impairment, confusion, falls, dry mouth, constipation, urinary retention, and increased risk of dementia. Many older adults are taking 3, 4, 5 medications with anticholinergic effects, and have no idea. Their doctors may not have added it up either. This is why a comprehensive medication review is so valuable, looking at not just what each drug does, but how they interact as a group. Now, I know some of you may be feeling overwhelmed or worried, or perhaps defensive after all. You've been trusting your doctors to manage these medications, and now some professor on YouTube is telling you there might be problems. Let me be clear, I am not attacking your doctors. Most physicians I know are conscientious, caring people who want the best for their patients. The problem is the system, not the individuals. The system incentivizes prescribing over deprescribing. Insurance pays well for adding treatments, poorly for taking them away. The system creates time pressures that make comprehensive medication reviews impractical. The system generates guidelines based on evidence from younger populations and expects them to apply universally. Your doctor may not have the time, the training, or the systemic support to do what ideally should be done. Regularly reviewing all your medications, questioning whether each is still necessary, considering the cumulative burden, and making thoughtful decisions about reduction. But you can advocate for this. You can ask questions. You can be an active participant in your own care. So what do I suggest? First, know what you're taking and why. This sounds basic, but many patients can't tell me what their medications are for. Before you can make good decisions, you need to understand what you're putting into your body. Ask your doctor about each medication. What is this for? What are the side effects? How long should I take it? What would happen if I stopped? Second, ask about deprescribing. This is a term we use for the careful, thoughtful process of reducing or stopping medications that may no longer be beneficial. Not all doctors are familiar with deprescribing, but the concept is gaining traction. There are even guidelines for deprescribing specific drug classes. If your doctor isn't receptive, consider seeking a geriatrician, a doctor who specializes in the care of older adults. We are trained to think about these issues. Third, request a medication review. If you're seeing multiple specialists, a cardiologist, a gastroenterologist, an endocrinologist, and so on, each may be prescribing medications without a clear picture of what everyone else is doing. Someone needs to look at the whole list. Your primary care doctor may be able to do this, or a clinical pharmacist can be invaluable. Many communities have pharmacists who specialize in medication reviews for older adults. This service is often covered by Medicare. It's worth asking about. Fourth, be honest about what's happening. If you're experiencing fatigue, confusion, dizziness, falls, digestive problems, or anything else, tell your doctor. Don't assume it's just aging. Don't dismiss it. These symptoms are information, and they may be pointing to medication effects. Fifth, support your body's ability to handle medications. This means taking care of your liver and kidneys, staying hydrated, avoiding unnecessary toxins like excessive alcohol, eating a nutritious diet. It means maintaining muscle mass, because frail people are more vulnerable to medication effects. It means being thoughtful about over-the-counter medications and supplements, which can interact with prescriptions. I want to share one more story, if you'll indulge me. A few years ago, I saw a woman named Eleanor. She was 82, a retired librarian, still sharp, still engaged with life, but she developed a tremor in her hands that was getting worse. She was also having trouble with constipation, fatigue, and what she described as a fuzzy feeling in her head. Her doctor had told her the tremor was probably early Parkinson's disease and had referred her to a neurologist who wanted to start her on medication for Parkinson's. Before we did that, I reviewed her medication list. Eleanor was taking a medication for nausea that she'd been on for years. She'd had some stomach issues a while back and just kept taking it. This medication, called metoclopramide, is known to cause movement disorders, including a Parkinson's-like tremor. It's supposed to be used short-term, but Eleanor had been on it for over 3 years. She was also taking an antidepressant with anticholinergic properties, which could explain her constipation and mental fogginess. I suggested we try stopping the metoclopramide carefully under supervision before concluding she had Parkinson's disease. Within 2 months, her tremor was significantly better. Not completely gone, but about 70% improved. Her constipation resolved. The fogginess lifted. Eleanor did not have Parkinson's disease. She had medication-induced Parkinsonism, a problem caused by a drug masquerading as a serious neurological condition. If we hadn't caught this, she would have been started on Parkinson's medications, which have their own side effects for a condition she didn't actually have, and the medication causing the problem would have continued indefinitely. This happens more often than you'd think. As I wrap up, I want to leave you with a few thoughts. The first is that more is not always better. In medicine, we often operate under the assumption that treating every number, addressing every symptom, and preventing every possible future problem is the right approach. But in older adults, this philosophy can backfire. Sometimes the treatment becomes worse than the disease. The second is that you have more agency than you might realize. You can ask questions. You can request reviews. You can advocate for yourself. You don't have to passively accept whatever is prescribed. This is your body, your life. The third is that reducing medications, when done carefully and appropriately, can sometimes be the most therapeutic intervention of all. I've seen patients recover from symptoms they thought were permanent, regain function they thought was lost, simply by removing drugs that were no longer serving them. This is not about rejecting medicine. It's about practicing smarter medicine, more thoughtful medicine. Medicine that recognizes the unique vulnerabilities of aging bodies and adjusts accordingly. I'll close with this. When I teach medical students and residents, I often tell them, the first question you should ask when an older patient develops a new symptom is not, what medication can I add? It's what medication might be causing this. That simple shift in thinking could prevent enormous amounts of suffering. If you're watching this and you're on multiple medications, I hope you'll take some time to reflect on what you're taking and why. Talk to your doctor. Ask questions. Be curious and engaged. Your body has carried you through 7, 8, perhaps 9 decades. It deserves thoughtful care, not just more prescriptions. Thank you for watching today. If you found this valuable, please share it with someone who might benefit: a friend, a family member, anyone who's managing multiple medications and wondering why they don't feel as well as they'd like. And if you have experiences you'd like to share, successes with deprescribing, frustrations with the system, questions about specific medications, leave them in the comments. I read them. Take care of yourselves. Ask good questions. And remember, sometimes less really is more. I'll see you next time.